Namaste, good morning, warm welcome to one and all. Today we are starting our first live workshop CME on microwave ablation of uterine fibroid and adenomyosis. So let us start with this CME with the God chanting through a small Sanskrit shloka. Gurur Brahma, Gurur Vishnu, Gurur Deo Maheshwara, Guru Sakshat Parabrahma, Tasmai Shri Guruve Namaha. As we know, day by day more and more innovation, new techniques emerge in the view of to avoid the hysterectomy and to save the life, also to decrease the morbidity of the female, to improve the quality of life of female. To know more such about the microwave ablation of uterine pathology, we have our most energetic young stalwart Dr. Shankar Nayak sir. So I handed over the mic to our treasurer Dr. Chandrakant Jadhav to proceed further.
Hello, good morning to all. I welcome to this live workshop that is with associations of AMOX Midlife Committee and SOGS. They are today's Dr. Shankar Naik was done his MBBS and MS General Surgery, and he has done his fellowship in laser endovenous surgery, also done his fellowship diploma in urogynecology and diploma in robotic surgeries. He has also certified microwave surgeon from the China CCMA, and he has higher end surgeries he is doing, that is the histoscopic laser laser histoscopy also he is doing, and he is certified course in laser ablations in the prostate surgery also. Basically he is doing all types of surgeries by microwave ablations, but today we are inviting her for the fibroids and adenomyosis, but he will highlights the more about the microwave uses in the other sides of body also. He is giving the training for the microwave in the laparoscopic assisted ultrasonic guided microwave ablation of uterine fibroids and the percutaneous abdominal uterine fibroids and the histoscopic microwave ablation of the endometrium. Also he is giving the training in that. He has his own YouTube channels, and he is very innovative surgeon. He is doing vaginal uterine arterial ligations for the uterine fibroids, adenomyosis, and the arteriovenous malformations. Over to you, to Dr. Shankar Naik, sir.
Good morning, respected professors, teachers, seniors, gynecologists, and my dear friends. Today I am very happy to be a part of AMAX Midlife Committee giving this opportunity. So life is changing, scenario changing, mechanics changing, biophysics changing, so the technology also changing. So any doctor update, very important, like a software applications. So very important to survive in the society. So nowadays the things like a save uterus, very, very important, play key role in the Indian society. Even Supreme Court laws are changing. So coming to the microwave ablation in gynecology. So microwave is a thermal energy. As an Indian, we believe, like a Hindu, our body is made up of 5 elements, Panchabhuta. You know Panchabhuta. So we are using all Panchabhuta to treat one disease. Like we are using fire, treatment with fire for fibroid adenomyosis. This is a generator manufactured from China. It's supplying 130 to 140 countries throughout the world. They are leaders, micro manufacturer leaders. For this generator for manufacture for liver tumor, now all cancerous ablation, now they are changing to benign tumor also. So one machine, one hospital, many uses. You can use this machine except the brain, all pathology like a thyroid ablations, thyroid nodules, a lung metastasis, liver nodules, even gastric, pancreas, renal, varicose veins, hemorrhoid, proctology, everywhere you can utilize this machine. So this is an antenna. So these are different antenna, different size for different organs. You know the biophysics, this microwave generator, like a laser, the energy from the light source, light amplification, it's a major, means there is magnetron inside, it releases electromagnetic waves. So electromagnetic waves are more effective than the laser. So the wavelength is in between radio and infrared rays, and more effective, more ablation, faster energy than the laser. How basic physics, basic principle of microwave. So when microwave touch the cells, it disrupts the water molecule. H2O, it act on the H2O, it disrupt, it breaks the H2O, two hydrogen negative atom, one oxygen positive atom, and it causes heat. Once it increases the heat, the cell death will happen. Once it creates friction, so cell death is happen. That is the main basic mechanism of electromagnetic waves. That is a microwave. So once the temperature, if you increases like 40 centimeter will cause cell injury, 45, 46, 60 minute will cause cell death. Instant 60 centigrade if you apply, instant the cell death is occur. So how it act? So for example, a 5 centimeter fibroid is there. The company guidelines are there. The how the antenna, where rays are open like a ablation zone, the ratio of ablation, it's watts. The company given watts, energy level and the time. This will be reciprocal, how much ablation zone you want, 3 centimeter, 5 centimeter, we should follow the company guideline chart. I will show you. So this is the mechanism. I told that is a ablation zone and the conduction zone. Direct heating is ablation zone, and from there indirectly is heating also there, that is called conduction zone. So this is a chart given by the company in your porcine. They are scientists, how the tissue is reacted. So you should follow this time and watts. Generally in gynecology we prefer 50 to 60, 70 watts. If you use the 100 watts, you should be careful. More watts if increases, more carbonization. Once more carbonization cannot, what you call phagocyte cannot take in body, painful necrosis. I will explain later. So this is the chart you have to follow. So the basic in liver, how it's acting, you see how the ablation zone is forming. So it acts on the lateral spread. We are afraid of lateral spread when you are using vessel sealer in the hysterectomy. But the mechanism here is a lateral spread. The conduction, radiation, this is electromagnetic waves, electric magnetic radiation, it is slowly increasing death, causing cell death to this is called ablation zone. So when temperature, when watts is increasing and time increases, it increases the ablation zone. One single time you can do the 3 to 5 centimeter ablation. So this is a thermal effect, 80 to 100 cells heat, cytotoxic effect, cell death, coagulative necrosis. After coagulative necrosis of cell death, the body, your immune system play key role, that is eaten away. It's become a foreign body in your body. Once then the tissue repair mechanism, like a phagocyte immune system, that is called apoptosis and phagocytosis. I will explain. Once if you are giving more than 100, but it's called carbonization. Carbonization cannot be eaten by the macrophages. This is a basic of this. This is coagulative necrosis. Meaning is, like boiled maize and or like charring maize. Like so, specific temperature of 85 to 100 if you apply, that's called coagulative necrosis, like a white cooking. That tissue is easily taken by the macrophages. So you will get a doubt that once you are ablation, how it volume reduction. I will come later. This is called volume reduction process, that is called phagocytosis, apoptosis. All the debris or coagulative necrosis tissue taken by our own body immune system mechanism. How that is the reason a 5 centimeter fibroid decreased to 1 centimeter. No degeneration, no liquefied, nothing, only for the eaten away. For example, if you see in the varicose veins, once you ablated, after 3 months you can't see vein over in leg, where it is gone. It is eaten by our own body. Our body is a non-vegetarian. Okay. So coming to the application of microwave in the gynecology, very interesting. 2017 China was started. They have a evidence and they have experience on the benign tumor of a fibroid, adenomyosis, endometrial ablation. It working. The microwave kills cancer cells, microwave kills the benign cells, microwave kills the normal cells also. The fire can kill anything, simple thing. Now indication. So there is no FIGO classification. 0 to 6 we can do the microwave. 7 we cannot because it's a pedunculated. The stack, if you ablate also, it fall in the abdomen. Abdomen low where phagocytosis, apoptosis cannot take place. And the limit, the size of limit is a 10 centimeter you can ablate. But we prefer 6 to 7 centimeter initially. So 10 centimeter very difficult, but the company guidelines or other European or even China Gynec Association, they are doing up to 10 centimeter. The minimum size is asymptomatic we don't do, but symptomatic minimum size you can do 3 centimeter. 3 to 10 centimeter you can do the ablation. Adenomyosis, it's compared to the what we are observing fibroid adenomyosis, the microwave more working. It's a good result we observe in the adenomyosis because it highlights of mucous glands. So water is more, so it action is more. So fibroid we have extracellular matrix disintegration or apoptosis taking volume reduction low compared to the adenomyosis. The best result we observe in the adenomyosis. The vice versa, adenomectomy a complex surgery, very difficult to do, but myomectomy easily can do, but here is the vice versa. The contraindication, here the malignancy we don't, PID, coagulopathy, blood disorder we don't do it. Coming to the treatment procedure, it is a OT procedure, operation theatre, and the preparation and selection case. Selection case very important for Indian mentality, Indian scenario. Our Indian patient, they are expecting one-time short results. So you should counsel very better way. This is a volume reduction position. This takes 6 months to reduce 90 to 80 to 95%. So education, counseling very important. And so routine, the time, appropriate time after menstruation 3 days before ovulation is the best time. Preparation, if you have IUD insert, you have to remove whatever in the before do microwave. So selection patient, then the main problem, like a pathway where the microwave antenna entering the uterus targeting lesion, you have to which is select whether abdominal route or vaginal route. Okay, so previous cesarean section, adhesion myomectomy cases, you have to take abdominal route via laparoscopy. So selection case, you have to main safety is very important. How to enter target lesion to fibroid or uterus. So because to avoid bowel injury, other injuries, other organ injuries, so you have to take care of this. So the technical ablation are two types. For example, this is a fibroid 5 centimeter. We'll put a antenna inside, hot needle, what you call, it's called antenna, the needle. So we'll keep in center, and depending on chart you have to follow, at least 1 centimeter, 2.5 minutes. Like a 5 centimeter, we use 10 to 15 minutes ablation. This is called overlapping technique. Because of radiation, it's lateral spread and it causes the ablation. You try to understand? This is the overlap technique. Another technique we do for example, 5 centimeter fibroid, we do 10 to 15 minutes, like a 90-second pulse model, like 90-second will come like a 1 centimeter, then 90-second we are giving multiple puncture, multiple shots, and moving shot technique. We applied in the infertility or patient suffering from the infertility fibroid adenomyosis, very safe technique. Same technique we do in other organs also. So moving shot technique you should know, and the overlap technique, these two techniques we apply in the ablation. So this is a moving shot technique. So it's covering all the fibroid, all pathology. The same thing, moving shot technique. So guidelines. The guidelines for the fibroid adenomyosis, now recently even European, American gynecologists, they are more, American, they are doing more radio frequency. So other like China, European, even Korea also they are doing microwave ablations. So first they prefer ultrasound guided microwave ablation for fibroid adenomyosis. Second option is the surgery. Okay, and but Indian not at, because recently 3 years we have started. You have to maybe we'll get some permissions, guidelines, takes time. Now the plan of action, route map. Once a patient came to you, you undergo the ultrasound, take the ultrasound, and even also MRI you can plan. So make it 2 reports fusion, make a road map, where is exactly the location, how many fibroids. So 2 reports make a fusion and the route map, and specific size located, and the posterior, then your approach will be changed. For example, posterior fibroid there, a radiology, intervention radiology, they do very better with a transvaginal route. Anterior there, they do with ultrasound guided this one. Previous cesarean, multiple adhesions, other ovarian cyst there, the concept is changing. Now you can do with laparoscopy. So that is the advantage. So this is approach, figure classification. You can see 0, 1, 2, you can do hysteroscopic, even ultrasound guided, but 2 to 5 laparoscopy or ultrasound guided. Choice is depending on team work, multidisciplinary team. The gynec and radiologist they decide. Anesthesia, it's a choice, general anesthesia, epidural, spinal, it's a choice. Local we cannot do because it causes heat and pain. We cannot try in local, like even cervical block, paracervical block we can't. Coming to the anterior fibroid, anterior all of the adenomyosis, even the fundal region, you go to the only ultrasound guided. This is a percutaneous method. Ultrasound guided method can be done easily, only preferably that anterior wall.
See the angulation, in-plane approach. Okay? In-plane approach.
Sound please.
Okay? We are entering into the direction. Okay? We are entering into the abdominal wall. So the safety is very important to avoid intestine, bowel injury. Position, you can see the head low position, and you can see now this is uterine elevated. This is uterine elevated is there. Okay? Uterine elevator, this is a mandatory.
Simple one video. This only most of intervention radiology they are doing this type of ultrasound guided microwave ablation, but its only limitations are there and required very skillful, very dangerous, because the uterus is mobile. Once you are entering in the needle uterus, sometimes it may move, sometimes it bleed. So the most of radiologists not willing to do this. The game change. No. Okay. So the advantage minimal invasive, but a disadvantage is more difficulty creating saline inside artificial saline. I will explain. Penetration antenna, posterior fibroid very difficult. Safety very concerned. Bowel, bladder, previous cesarean adhesions, all these are main problem. We cannot do bigger size, more time ablation. So this is the bleeding. Once you are entering and missing out, it's bleeding, we cannot control. So that is the reason, this is the main reason microwave machine is handed over to the gynecology now. The play of next is laparoscopy. Safety concern, laparoscopy. This is just how the okay. Thyroid, varicose veins, liver, all this done by the intervention radiologist with a microwave. Some of the radiologists they are doing uterine fibroid, but most of them they are not doing. Reason is that I told the previous reason. Get some water. Okay, I'll change. You see the bleeding, this type of bleeding cannot control in the ultrasound. Okay, no. It's not playing. So this type of bleeding, you said it's a bleeding, it cannot control by the ultrasound guided. Now the role is coming as laparoscopic, even ultrasound, both. Laparoscopy, we are taking assisting, laparoscopy assisted, ultrasound guided. This is called Lumba. This method says very improved, and safety is concerned, safety is important, and this can be familiar with the gynecology. So nowadays we are doing 3 mm needloscopic, minimal 5 mm scope, that's enough. This is adenomyosis case. This is China. You can see the adenomyosis, multiple puncture, multiple shot, moving technique done by the Chinese surgeon. I was there that time. You can see. China concept is a woman without uterus, not a woman. Their scenario there. So more conservation. Even patient are educated. Patient bearing the pain, post-op pain also, and follow up. Very very good in China. The same thing, adenomyosis laparoscopy. I'm just skipping all the videos. The advantage, under vision, you are doing ablation under vision, ultrasound, vaginally, you can see the ultrasound laparoscopically. So here the more advantage, bowel, you can avoid complication, and bleeding also control. You can treat other diseases like ovarian, endometriosis. So this gift for new energy for a gynecology, microwave. So once you have done the ablation, how to know how much you have done? What is the specificity, like efficacy? How much you have done? For example, 5 centimeter fibroid you have done. You can check with ultrasound, giving contrast injection, sonovi, or you can do the Doppler. So you can see the Doppler blood circulation, and contrast also you can see, because there is no blood perfusion, you can see black hole. And if you see the residual part, missing part, the same time, the radiology will help us to do this part also. How that way you can reach 80 to 90% ablation. Ablation, full ablation means only 80 to 85%, not 100%. If you ablate a 5 centimeter, 4.5 centimeters, if you ablate it, that's enough. So that is, you can use the contrast as well as Doppler. The assessment, and only see 80, this is the assessment ratio. If it is 80%, the complete ablation, 60 to 99, 79% is mostly ablated, below 59 is a partial, 15-20% is ineffective. You can see the Doppler as well, contrast. The follow-up, this is not a removal procedure, it's a volume reduction procedure. You have to follow first post-op day, 1 month, 3 months, then 6 months, and the 1 year. 1 year, after 1 year is cut off. Those 3 months very important. Whatever you have done ablation, the size should be reduced 50%. That is called very significant. If it is reduced 30 to 49, significant, and if it is below 30 is ineffective. What are the complications? There are major complication, minimal complication, pain, fever, vaginal discharge, some heat conduction, vaginal scalding. We observe vaginal some discharge, like white discharge for 10 to 15 days. That's manageable. Only it's self, limited. This is the main complication when treating the infertility case. Endometrium should be protected. So this, your heat cannot transfer to the endometrium. We have special procedure like a protection of the endometrium. And the bleeding you can control with the bipolar. All the bladder, intestinal injury, it's a very major complication. You try to avoid by laparoscopy. So one of the biochemical reaction, hyperkalemia, when you are doing more ablation, more than 15 minutes, 20 minutes, you have to change electrolyte imbalance also, hyperkalemia. Coming to the infertility. When you are doing ablation, I told endometrium should protect her carefully by using, SSG catheter, endometrial manipulator, uterine manipulator. Always use saline irrigation inside. So this will protect the endometrium. And you do the moving shot, and you do the under ablation, not more than 80%. Try to avoid, very important, the infertility. There are evidence results in China. They are applying microwave for infertility. So this is the evidence. the posterior wall of the located main leiomyoma, that is a fibroid. Now you see the 12 months baby after 12 months. So this is the follow-up I told. What is the compare advantage to the hysterectomy? So what is the importance? You know the complication of hysterectomy, support value, sexual that region. So this minimal invasive compared to the hysterectomy, very, very minimal invasive. You are preserving the uterus, and the beauty is it cannot hamper the ovarian malfunction, ovarian blood circulation also. If you go for like a uterine embolization to save uterus, when you are doing radiologist by uterine embolization, it hamper the ovarian functions. It also disturb the ovarian function. Compared to the myomectomy, though it's a very important, it's a very good question everybody raises. When gold standard myomectomy is there, why should we go the microwave? But there are more advantages. You know the myomectomy, it's a complex surgery. You need skilled, like you need to suture or remove, and need endobag to marsulate, and bleeding, infection. And the main thing is, if you are giving a incision in the uterine wall, myometrium, it causes the weakness. Suturing, it causes fibrosis, weakness. And it is the antenna, 1.5 mm, the thickness antenna, it can ablate the fibroid. So the recurrence, if you think it is in the myomectomy also, more recurrence compared to the microwave. So that is the reason we can compare the, so comparative study. Now it is a gold standard, but future microwave may be going to be a gold standard. What I am to say. This okay. That is the scar. When you are doing a previous like a cesarean section, why do you prefer lower segment? If you are doing a myomectomy in fundal region, its weakness are there. How you do Pascal, how strength you do Pascal, you know the measurement strength also. If you do robotic also, the scar weakness always there. In ruptures, pregnancy rupture, you know the percentage. Even multiple fibroid, multiple incision required, more scar required, smaller fibroid were missing, it caused recurrence. So follow-up, 6 months pregnancy for myomectomy. Compared this microwave, the minimal invasive, daycare, speedy recovery, and I told antenna size is 1.5. You can do multiple. Weakness scar is never seen. Adhesion, post-op adhesion never seen. Bleeding you can control. No need to have a skilled suturing techniques. And easy there, learning curve is shallow. And the evidence are there, spontaneous pregnancy. You know the ovarian blood supply not hampered. This is the advantage compared to the myomectomy, microwave ablation. So I want to compare this microwave for other. Sari is asking hypos. So this is a hypo. Now this is a non-invasive completely, like ultrasound. This ultrasound, high frequency ultrasound, we are using, we are converting like this rays goes like this and it causes heat. So non-invasive, and we have a complication, more expensive, and the results are not good compared to the microwave. You know, uterine embolization. People are radiologists, they are doing uterine embolization for fibroid, even selective embolization. Though the results recurrence are more, we have a syndromes like embolization, very painful for 15 days, vomiting, suddenly if you stop the blood circulation. So these are the things are coming, and recurrence is more in this case. So if you compare microwave radiofrequency hypo, you know the radiofrequency is nothing but the alternate current. It has got its limitation, and it is not faster than powerful than the microwave. So you can see the limitation, and but microwave you can ablate more vessels like a blood circulation, feeding vessels. So this is very powerful than the radio frequency. So advantage percutaneous ultrasound you can do, real-time monitoring ultrasound you can see, effective, significantly reduce the volume, eliminate the significant, improve the clinical symptom, preserve the uterus, short ablation period, large volume fibroid can be ablated, lesser side effect. So this is the experience. All the most of I think even European, Korean, Chinese, the people are doing since 2017. Now they are doing all the cases. I have seen the one hospital daily 10 to 15 cases microwave ablation of uterine fibroid, one hospital. Coming to the Indian concept, Supreme Court order is coming soon. Below 40 years, if you do hysterectomy, you take district committee permissions. That's very headache for us. So what do you do? This is a golden time, new with the game changer, gold chance to us to give a choice, give a treatment with a microwave for this below 40 years. Say no to hysterectomy, myomectomy, say no, yes to the microwave ablation. So this save uterus concept for fibroid adenomyosis, family completed patient, what we are doing, we have a design program like we are ablating over ablation. For example, 5 centimeter fibroid adenomyosis is there. We are ablating, more ablating, even endometrial ablation also done concomitantly. Try to understand. We are over ablating. So this same time we are doing even salpingectomy also, laparoscopy. Because salpingectomy has more pathology like hydrosalping, pyosalpings associated. One-time settlement like sometimes we do fimbrectomy. And once you are doing over ablation, there is a endometrial debris will form. To avoid pyometria, hematometria, we are doing just like a debridement, D&C suction debridement, and we are putting copper teeth as a drain for 15 to 1 month. Whatever secretion will not jam inside, so it will come automatically. So this is we are doing since 3 years. We have done more than I think 220 to 26 cases. 1 or 2 cases got some pain, complication, we have done hysterectomy, but rest of this they are very well. So third indication, especially interesting chapter, like AUB, DUB, what you call, this is endometrial ablation. We do trans-abdominal ultrasound guided endometrial ablation. We have a special antenna for this. I am one of the member for R&D in that designing program. This is a special antenna. It goes through the endometrial cavity and it ablates the endometrium. So this is just animation video. This is seeing the ultrasound. You can see this pointer. This is seeing by ultrasound. Well. Clarity is not good, I think. You can see, observe white gasification. You can see the firing inside. Okay. So there is a TCRE gold standard. Now the claim is TCRE is gold standard, and in that we have a complication learning curve more, and we are going the osteal side from TCRE. You cannot do it. There is a leftover residual part. That is the reason regeneration, recurrence, and the more volume overload. TCRE needs doing a bigger instrument inside. You need a dilatation, cervical, all things. So this is very important because it goes the spread, heat spread up to till the myometrium. You have a myometrium, arcuate artery, basal, radial, spiral artery. You have till the basal artery, you have to ablate. This is the only thing, the radiation of this is possible. You can, sir, Gurram sir, we do with hot balloons all the earlier. There are first generation hysteroscopy, second generation simple like hot balloons, hot waters. They have derma choice, even there are Minerva something like, there are many gadgets. But what the problem in that, that heat cannot conduct, heat cannot go and ablate the radial spiral arteries. They are not reaching the myometrium. So that the recurrence very possible in that case. Here you can completely ultrasound guided, you can reach the myometrium. Once you have an 3D, 4D ultrasound easily under vision, it's not a blind procedure, it's easy, you can ablate all the even myometrium level also. So you can reach osteal side also, because the antenna designed like a bend you have seen, we'll show you the antenna bend. So you can reach osteal side this. So this type, we can do even the myometrial fibroid adenomyosis simultaneously with this type in this. Only for TCRE, we cannot do that. We can do, but experienced hand might be they do. So we can do the other like a pathology same time. So this is showing a better result to save uterus. You know the AEB 30 to 40% DUB, and even the 15 mm, 16 mm endometrium we can ablate this. Sorry. Coming other indication, this is an infant stage, like a scar endometriosis, abdominal wall scar endometriosis. You can ablate that fibrous tissue also, ultrasound guided. One of the China doctor, Guang Xiaoming is doing. I have done 2 cases. That results are, it's good. Pain is comprehensive is there. One case got infection, but one case is good. Second, third case we are publishing this series of information. Next important is the post MTV AV malformation. What we do generally hysterectomy. But radiology, they do uterine ablation. But sending to radiology, complication, and the expensive cath lab. You know the uterine very expensive. So if you see the ultrasound guided AV malformation, go there, you can ablate that area. Ultrasound guided AV malformation, there is myometrial, inside myometrium. In that myometrium, you go and put an antenna, you can ablate. That is the reason you can stop the bleeding. What is the future upcoming? So this is a special laparoscopic transducer probe through ultrasound. You know ultrasound. The ultrasound we do with laparoscopy. You know BK Medicals, they design the ultrasound probe laparoscopically 10 mm. You can put the ultrasound Because when you are doing laparoscopy, ultrasound is become a very difficult to do abdominal ultrasound because gas CO2 inside. Vaginal you have also difficulty. So they designed the laparoscopy ultrasound probe. We have a 5 mm, 10 mm probe. So you can easily, you can do with it by seeing the ultrasound same where you can easily ablate. The second innovation is this is a endometrial ultrasound. You can see the endometrial ultrasound going the endometrial cavity. Transvaginally, you can ablate the fibroid adenomyosis. This probe is going inside. You can see it in ultrasound also here. A very supraminimal invasive you call. Now you can ablate. Doing myomectomy, this type cases and doing this, the energy, technology is very, what you call, minimal invasive, always minimal complication. Thank you. Feel free to ask any doubts, questions. The machine expansion, everybody will ask the doubt. What is the expenditure? I think there is two type of machine. One with varicose vein, one with this machine is 17 to 18 lakhs. The antenna is 55 to 60,000. But that is antenna for disposable. You can use 5 to 6 cases. We generally do like that to maintain. What? Post-op management. Cost of procedure we charge 80 to 1.2 lakhs. Nowadays initially we are doing because of more cases we want to get experience, 80,000 we are charging. But like a cooperative hospital you can charge less compared to corporate. They are charging in Apollo 2.3 lakhs. Mimi Bindra, she is doing from Apollo Hyderabad, 3.5 lakhs. What procedure?
Fetal procedures.
Fetal
Procedures.
Yeah. Fetal reduction you are talking.
Yeah.
Yes.
Monochorionic twins.
No, this is a more energy compared to laser, sir. It's a very stronger energy. We can't applying there.
No, radio frequency is also used.
Radio
for the
frequency
fetal.
is a lesser, but laser they are using fetal reduction. What do you say that one?
Yeah, microwave is also used for this.
Maybe, but we can utilize same thing. You want to kill the fetus, no?
Do they have this company has probes for that?
No.
You are not.
No, maybe I don't have idea.
That's
I will find out. That's a good question. Yeah.
Using the vasopressin will reduce the puncture bleeding.
Vasopressin.
Injecting into
No.
the myometrium.
You can track ablation. You can do.
Achha.
Wherever bleeding there, you come and
Yeah,
you
just
can do the
while
bleeding.
you are coming.
Yeah. No. It's not. So okay, we can wind off or anything. And we are also doing a laser hysteroscopy workshop regularly. Next time if you are interested, we do laser hysteroscopy, polypectomy, enucleation, fibroid inside. It's easy and septal resection. And we are doing we are enucleate the fibroid. We are keeping inside only. After 1 month, 14 days, it's fall automatically. No need to resection, doing myomectomy, and you don't need to spend more money like a true clear, what you call oscillators. It's very important. It's a good subject, laparoscopic structure, hysteroscopic laser. No, it's only coagulation. You need cutting also. Laser will have a very penetration is one, because to endometrium, to protect the endometrium, the laser has a penetration 2 mm. So easy cutting, this will blast, this will spread, more radiation will spread. We can use all the other like proctology, hemorrhoids, like a fistula, we can use varicose veins.
Thank you, sir, for such a wonderful and elaborative lectures. We are all know that this is the new door open to our faculty, that is the OBGY, and they rightly, sir, said that the machines came from the hands of radiologist to the gynecologist. We should use that. Okay.
You should test this energy.
You have also elaborated the limitations of the surgery, that is Fibroids 6 classification, that is pedunculated fibroids, and more than 10 centimeters we should not touch with the microwave. That's we should go for that conventional therapy.
More than 10 centimeters, doing always like open is the best, my concept. 15 centimeter open always life saving, and even better in doing marcellation, seedling the tissues are a very problem.
This is the super minimal invasive surgery, and this gives at least no scar to the patients. That is the most advantageous. And as we are going to the Goti, all people are eager to see the live surgeries. Before that, I will take a time for the lamp lightning. I request Dr. Ghate madam to be on dais. I request Dr. Gurram sir. He is a workshop coordinator, and also I am very thankful to him for giving a cases for this live workshop.
So now you can see here the machine. Yes, this is a machine. Regarding this machine, I will hand over the mic to Dr. Shankar sir. He will tell you more about that.
This is a very compact machine, just plug and pay. We have all the softwares application over here. You can have models. You can also register in this model for specific cases. So we have a watts here. You can increase the watts here. You can see this is a watts, and this is a time. You can increase or decrease the time. And the main thing here is you can Tumcent pump. We call Tumcent pump for this machine, because when the radiation is released, like a cable from heating cable, to avoid when entry point like a skin, abdominal skin or muscle, so we need a continuous irrigation of saline, chilled saline, cold saline, so that will protect our entry point. That is the main reason. And the heat only, I will show you the antenna, only the rays release only aperture, that is called active tip. So this is a very compact plug and play machine. This is from the China, the Eco company. So this is an old leading company. Right, thank you. Hello, Gurram sir is doing pre-op ultrasound. So the assessment, what is the pathology in endometrial cavity? It's associated polyps or fibroids, myomas, or any other pathology. Or if you have any IUD inside, you have to take out. So you see the ultrasound picture. Sorry, 1 minute. You can see the ultrasound picture.
Yes, sir, we can see.
Yeah, he is calculating the thickness. 6 mm thickness. Okay. So generally the company guideline says 50 watts 3 to 4 minutes, 70 watts 2 minutes. So we prefer to do with, because of 6 mm, we prefer to do with 50 watts. You can see now the 50 watts, the 4 minutes, 3 to 4 minutes by seeing the ultrasound. So we'll show you the antenna also, right?
So under what anesthesia we are doing this?
Generally, GS, because of group discussion, you can prefer spinal anesthesia also. No problem. It's a choice.
So
Patient choice or doctor choice, anesthesia choice.
in this patient we are doing under general anesthesia. Whether bladder is full or empty, or you want to fill the bladder with the Foley's?
It's a good question, madam.
Huh.
We full the blood. It's not 70%. We cannot full the bladder.
Huh.
At least 50, more than 50% will fill up the bladder, and we'll push the uterus inside. We'll lift because avoid thermal injury to the bladder.
So you are filling the bladder with normal saline or what?
Only normal saline.
Normal saline.
Normal
Okay.
saline.
Which procedure you are going to do in this patient? The audience are asking.
Yes, this is the AUB, and it's called DUB specific cases.
Huh.
Bleeding PV anemia. Sir is planning now the trans-abdominal, ultrasound guided.
Huh.
You understand?
Huh.
Then the transvaginal, transcervical microwave ablation. So we want to distract the endometrium to avoid menorrhagia.
How much endometrium you want to ablate?
Yeah, it's an 6 mm here. So we want to go at least more than 8 mm at least, above 6 mm.
Above 6.
I told because spiral artery should coagulated, should
Okay.
ablated.
Huh.
Otherwise the recurrence is more.
Okay.
Okay. So there are the like endometrial ablation, the first generation by hysteroscopy, TCRE I told. Second generation you have a cava-thermo, hot balloons, then radio frequency like a fan mesh. So these are the second generation. These are failure. The results not optimum. So now this is the very minimal invasive new energy for the destruction of endometrium. Right. Save uterus program.
Can we save the fertility in this patient?
No. Infertility you cannot distract that.
Huh.
Infertility, yeah. Huh? This patient is already tubectomized. This is tubectomized. This is family completed. We want to save the uterus. We want to improve the quality of the patient
Okay.
to avoid anemia.
Huh.
So the simple thing, the endometrial bleeding leaking, blood is leaking, ma'am. Simple. So
Okay,
hypermenorrhea.
okay.
So
Okay.
right. We want to distract the endometrium, whole endometrium.
Dr. Doshi is asking something.
Hello.
Huh.
This question is to Dr. Gurram.
Yes.
Has LNG been tried on this patient?
Sir, actually, I advised this patient regarding the LNG,
Huh?
but previously she had copper T. At that time, she was not responding well to that treatment. So, she was not ready to put the LNG. The other thing is, this patient had a thrombotic problems in the previous year, 3 year back. So, considering those two things, we advise, actually she was ready for hysterectomy, but for this workshop, I purposefully kept for endometrial thermal ablation.
So we should have similar workshops more and more.
Definitely, we are thinking of getting this instrument because this instrument not only used in gynecology for thyroid surgery, varicose veins. So, and I think one Solapur should have such instrument, right, sir?
Sir rightly point out what Marina sir saying, sir. LNG.
LNG.
Marina
Yes.
Marina,
company.
ah.
So the Marina, the results are not optimum, sir. So because of young patients keeping Marina, we have all medical treatment. We cannot expect 100% result. All medical, whatever, even this like IUD insertion. So we want here about 90% result with the microwave. Thank you.
Bladder full?
Thank you. We'll start with the procedure. You show us all the instrument, ultrasonography machine, microablation, ablator at the same time.
Okay, I will do.
Vaginally, what you are doing?
Artery forceps. Needle, 18 number. किंवा जे काय असेल ते. एक 100 ml normal saline.
Can I say something about the Marina?
Yes.
Well, say I'm the first person in country to put Marina in 2000. Since then, I have inserted about 3 to 4,000 Marinas in the AUB patients, and the results are excellent. 95% of the patients, they avoided we could avoid the hysterectomy. That is those are the results of Marina. These are personal results, mine results. I'm not referring to the literature.
Sir, actually, we have used Marina for many cases, and even fibroids, adenomyosis, in those cases also the results are good.
Yes.
But sometimes the patient, in some patients, they are not, the results might be good, but patient having some pain, etc. And in those cases, we have removed the Marina also. But the cases are few, not more.
Now we'll try with this new technique, no? This new technique is upcoming.
No, this is just to what actually what is happening, that we want to know. That's why we have keep this workshop today.
And we have to give the option to the patients that we can do this procedure also and save the
దీంట్లో
uterus.
నాకు ఒక 200 ml नील इडिशेड 200 ml अडॅप्टर घ्या म्हणजे ब्लॅडर फुल करायचं मला हां IV सेट और अडॅप्टर इकडे द्या हां हो गया चलो चलो
Needle cap you can.
no problem it is yes yeah
Air is going, sir. So air is disturbed. थोड़ा निकाल दो.
yes चल 200
Just
200 ml you can
200.
just confirm madam
Confirm.
yeah
Thank you.
Shesdare, adjust the camera on patient. It is on doctors.
no we are just putting the
Preparation is going on. Just
bladder we
Okay.
are filling the bladder with 200 ml of normal saline
7.5 gloves.
yes you can ultrasound you can pay on the ultrasound
Why
Okay.
this bubble?
yes we are filling the
Huh.
bladder
Enough, sir.
yes enough?
Yes, sir.
yes bus
We are seeing that.
Block it. Antenna, microwave antenna. What bladder is that? All flakes? No, bladder is all flakes.
Okay.
Some flakes are coming. Infection.
You are doing dilatation of the cervix.
Yeah.
how much up to what sir
That simple one, sir. For
no but up to what dilator
this.
Up to what number you dilated
number?
cervical
This is
canal?
number small.
so this is 6.5
6.5. That's enough.
6.5 mm is enough.
Because our is of this is only 20 what you call 20 mm diameter.
Yeah.
16. It did they give me? Yeah, I will show you.
you can
It's a very very thin. You can see. This is the microwave antenna.
Huh.
Okay.
Huh.
So you know this is the active tip.
Okay.
You try to understand. There is a like one. This is the active tip.
Okay.
5 mm active tip. White patch. You are seeing the white ring. This one. So this is a curved one. So it enter transcervical, reach like a right ostia, fundus, and the left ostia, body, anterior, posterior. Our target is. So our target here is the 6 mm. You can see the 2 centimeter cavity inside, 6 mm thickness. So we want to give 4 minutes, 3 to 4 minutes, 50 watts energy. Okay? So you know. So come. Come closer to bring closer. No, all this you remove. Foot pad. Yeah.
All these tubes you have taken, those are
I will-
sterile
I will-
tubes.
These
Huh?
are all sterile one.
Sterile.
You are seeing this sterile one.
Huh.
This is the main cable
Okay.
from the electromagnetic microwave comes from here. Okay? Transfers here, going from and release from this tip.
Okay.
This is the main important. What we are doing is making this cool antenna. It cannot damage the other structure, entry point. So we are putting normal saline. Hold it. You can see the normal saline side. इधर ही रख लो ना. Stand. ऐसा पर हाँ. Stand. So there is a we call blue male and female. It continues circulate the normal saline inside. So this is entry point will cool, make a cool.
okay
For
Okay.
this. That is the reason. गॉज पीस, सलाइन गॉज पीस. फुट स्विच डालो, फुट स्विच दे दो, इधर नीचे करो थोड़ा. या थोड़ा आप थोड़ा
नीचे दे दो.
नीचे दे. सिस्टर కొంచెం you can జరగమ్మా. Keep this. Okay. See folds. Okay. Right. Start on, machine on. 50 watt 3 minutes. You can see second one, foot switch control. Second one, 90 seconds आता ना. Do you know? Foot control, second. Yeah. That's the best. 50 watts. Now we.
Before putting, what precaution one has to take before putting that?
Yeah, you have to check the machine is working or not.
So show us what you are checking.
With this machine, I am checking the machine, it's working or not. I am starting here and I have taken the wet gauze. Okay, now you can see the sound and heating also.
Yeah.
So it is burning. So now the machine is working,
Full
right?
body circle.
Before inserting, okay? You understand?
Sir, आवाज आ रहा है.
Yeah, you come, sir. You can. Sir is going to introduce inside.
हाँ.
So, section, कुछ section नहीं है. No.
And when to introduce the liquid then?
Ultrasound, please.
We will clean.
Okay, clean.
At same
okay,
time,
okay.
normal
Come,
saline.
ultrasound. Come on, take out this. Remove this visor, simple. Pakad.
Now you are putting
Yeah,
into the cervical canal.
Yes.
Okay.
I'm going inside. Now you can
Uterus is
check.
activated.
Now check and you can off the light here.
the light.
OT light. Camera focus on ultrasound.
Okay.
Oh, okay, madam. You can check this.
हाँ,
I am reaching the fundus. So I want to reach the patient my right side of the ostia. So I am bending here. You can see I am the right side of the ostia. Right?
We are getting.
Okay.
Okay.
I am going to start the fire for 1 minute here. Now you can continuous. You can see the ultrasound monitor. How you see now? Now it's ablating. You can see there. Okay.
Yes.
You see?
Yes, we are seeing. That white.
White is spreading.
Spreading.
This is called steaming inside. When releasing hydrogen gases, oxygen inside, because disruption or H2O, it causes white. All gas ultrasound is in white, gasification. So micro bubbling.
Okay.
So
What you feel at that cannula? What you feel?
feeling it's like saline is moving in my cannula, and my concentration more over in the ultrasound. I am giving moving short time because the heat cannot spread the myometrium to reach the bladder or inner posterior. It's only up to the myometrium. I told there is at least cross the junction of the endometrium, myometrium at least 1 mm or 2 mm. So it coagulates spiral arteries. Spiral arteries. Then only the bleeding will control. I am told, you can see.
Is there any bleeding coming from the cervical canal?
You can check light, please. No, it won't coming off. We'll see. Because already we are coagulating inside.
Okay.
No, you can. No. You can see I am a moving short technique because it sticks sometimes. You see, you can check the movement also.
You reduce some gain of ultrasonography machine so that we can
No.
clearly see.
No. That's confusion. Once you are ablated, ultrasound also become a blind sometime. No, that rays cannot pass ablated area, dead area. So I am moving the anterior wall of fundus. Okay? Can you change the transverse direction, madam? I will show you the direction. Yeah. You understand, madam? Once ablated, the ultrasound cannot, the rays cannot pass. So initially it's good. You see now?
Yes, we can see.
Clearly ultrasound thick, you can. Yeah, now you can see. The firing is going on. The white gasification under the only myometrium.
Okay.
Sometimes you will get blasting sound also, doesn't afraid.
Bapre.
Simple sounds because bubbling. You can see there. Now I am cross right here, madam, longitudinal. Yeah, longitudinal. I reach the patient left to ostial side.
Okay.
Yeah. You can make your own road. There is how to. The main aim is to distract the all endometrium. No, we have to check with hysteroscopy.
Later on Doppler.
You can do Doppler and hysteroscopy.
हिस्टोस्कोपी कर एक कॉपरेटी लागेल नंतर
You can check the madam, no ultrasound.
Okay.
No, madam, going to check the endometrium with a Doppler.
Okay.
So any residual blood circulation or feeding vessels, she is doing.
Suppose newcomer is doing this and accidentally he perforated fundus. What sir we can do?
You have to refer to the case to general surgeons. No, that is the reason. It is an MDT, multidisciplinary
Because
team.
you are expert, sir.
No,
but
it's not a matter of expert,
surgeon
madam.
like me
No.
may perforate fundus, no?
See, madam, this energy has control with radiology.
Okay.
Radiology always we should know because legal problems are there. We should have a radiology team in team. Okay, madam. I am at madam.
Okay.
Hello.
Okay.
There is one saying, no gynecologist is complete if he or she does not perforate the uterus at least once.
Once.
and
Okay.
open the bladder.
And open the bladder also. That's a
No,
perfect
I am
gynecology.
asking whether to continue with this procedure or stop the procedure and do some other thing. That is the reason why I
You
am
always
asking this
go
question.
for, once you are suspected perforation, go for laparoscopy.
Suspected no, sir, we are seeing on the ultrasound. So your probe might be showing that you perforated.
because you
this
know,
is
madam.
thin one
Yeah.
instrument you are putting into the uterus.
Yes. Chances are there, or perforation chances are there, and these are marking always there.
Okay.
Say there is a Lakshman Rekha.
Okay.
You know Lakshman Rekha. You cannot cross. You see the ultrasound length you can measure, and you can put some ring here. You cannot cross with this. Simple Lakshman Rekha.
Sir, you are not getting. Even though passing the ring, I perforate the fundus. What I should do?
Laparoscopy.
Laparoscopy, go for laparoscopy.
Confirm whether there is injury or not, and if it is injury, then a surgeon should be involved in it.
Okay.
Yes.
Okay.
No, right. What a gas piece clean.
1 minute.
Wait. Yeah, okay, right. Yeah. Okay. Where do we just find out my antenna? Because after ablation, you are difficult to find antenna again. Just give me right. You can see white bubbling there. Yeah. That side. This side I want. Yeah. Resistance will be there. Ablation. I'm inside only now. Yeah. Because 2 minutes are over.
That is coming.
Coming, yeah. Firing is there, yeah.
Are there any automatic settings if the temperature increases up to certain level, it automatically stops in this machine?
No,
Not
we have a intelligence antenna,
Okay.
but not for this case.
Okay.
For other case like thyroid or in temperature rises inside, it will stop automatically. Intelligence cable antenna, temperature, another cable is there.
Okay.
Yeah.
For how many minutes we have to put that?
Yeah, company guidelines is 3 to 4 minutes because we are
Okay.
using very low 50 watts or 70 watts for 2 minutes, 50 watts for 3 to 4 minutes. Now you
Okay.
can check there is a white gasification total endometrium. There is some
Okay.
residual I am seeing in ultrasound. I want to target that. Okay, madam. You can check with the Doppler again. See any over in endometrium. What early picture is the same? Nothing is there. Okay. You want to see, sir? Feeling? Just inside.
It is like
Simple.
needle.
Yeah, yeah.
Yeah.
Maybe it's totally ablated.
Yes.
80%. That's enough.
Hello?
Any doubts? Okay.
Hello. How you come to know that 80% you have done?
Ultrasound, madam. I'm not seeing any Doppler or blood circulation in endometrium and no normal tissue in endometrium, all white gasification. You can see now.
Now here in audience we have Dr. Deshpande. He is urologist. He want.
Hello?
Yes.
Hello, Deshpande sir is here.
Hello, I gather you are doing this in prostate also, is that right?
Yeah, prostate microwave we are doing only for benign, like a, what you call
Yeah.
minimal, like 40
Yeah.
grams, 20 grams.
Is this similar to tuna?
Tuna is transurethral. It's only
Yeah.
transrectal ultrasound, perianal.
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 Okay.
We are entering into perianal. We'll show you the video to you.
So
Perianal.
not transurethral.
No. Perianal. We have a special antenna for that. We do that called transrectal, transperineal microwave ablation for prostate adenomas.
Okay.
Right,
Okay.
right.
So is there a procedure of laser ablation?
Laser only Italy people are doing, sir, for prostate.
No. In endometrium?
Endometrium ablation laser cannot roll because the wavelength and the depth of penetration only 2 mm.
Okay.
We'll check with hysteroscopy now. We'll see how anything residual or whatever leftover is there. We'll check how it is ablated. We'll see that.
Okay.
For only demonstration purpose.
Okay.
Let me call section करो.
Camera and its light source. And speculum valsalum.
Audience want to see irrigation.
Section
How much
tub.
normal saline required for the procedure?
Where is the irrigation?
No irrigation. It's only I'll tell
Acha,
you.
that is going and coming.
No,
in the same.
it's see in the camera, please. So there is a male and female we call blue and male. So it is running through the continuous circulation. So now you see nothing is in empty. It is full. One is filling, one is coming. Again, only maintaining this is cool. We have a inside like this circulation. So in entry point like a abdominal entry, skin entry from vaginal, it avoid burning. Okay. Once it comes from the copper white, it sometimes it heated. It some heat available, heat spreading is there. So to avoid this is circulation. We call it tumescent peristaltic circulation form.
Okay.
No. It's a choice. We want to see how the tissue is ablated.
Okay.
Generally we don't do.
Light.
It is.
Light. करावा लागेल. White balance.
Ultrasound can take out. Can you take out ultrasound? Yes, right. Okay. You can take out ultrasound.
हिस्ट्रोस्कोपी शेयर आदि
थोड़ा उधर अल्ट्रासाउंड निकाल के you can get it.
हाँ ओके
Huh? Stop the cooling. Stop it.
पानी
Now you are putting hysteroscope.
For demonstration purpose, we want to see the how the like a microwave cooking tissue.
Okay.
Whether is a bloody, there is anything residual or leftover, or you can see sometime perforation also.
Okay.
डायलेटर सिस्टर डायलेटर
You don't have 2.9, sir? Small. Okay.
नो वी आर हैविंग
Okay, छोटा. Section,
चलो
irrigation, saline.
चलो दे इरा पोतले
Need more pressure. Yeah. You can see the tissues inside.
We can see.
So you are seeing ablation.
Ablated white material is there.
All slough, what you call necrot.
Slough.
Yeah. You can see the, it's like after TCRE. Or roller ball, you do roller ball
Okay.
generally. Like same. You can, this, you see clarity.
या
Yes.
Yes, total.
Yes,
If anything,
can
some,
see.
yeah, you completed. You completed, ablated, you see.
Okay.
You are coming, sir? That's
आई एम
it.
कमिंग आउट राइट
Yeah.
एट द फंडस इट
At
इज
the fundus, cervical region we don't.
yes definitely this is the fundus
Okay.
now I am coming out you can see completely the cavity as I am coming out you can see the normal tissue
And
Yes, sir.
if you want now, you can do some slide like a DNC, you know, just curettage, debris you can remove, or you can, if you are suspecting like a pyometer, you can put a copper T for drains. It is a choice of this.
yes this is the normal tissue at the cervix
Okay. For how many days we have to keep
That-
property?
It's like depending on patient, we generally will keep for 15 days, 1 month.
property
It's obese case or more ablation. The associated adenomyosis will keep more days. It's choice.
Okay.
So anything you want to advise for modification or
Oh, I ask to the audience.
yeah.
So very wonderful job, sir. We enjoyed all your surgery.
Sir,
Yeah.
DNC was done beforehand to rule out any carcinoma or anything.
No, it's a very good question. It is compulsory. There is a process of already when you are putting cases ablation, you have to do all biopsy. Whatever DNC biopsy, you have to confirm it's only for benign.
Okay.
Then only you ablate. Even though accidentally, if you ablate endometrial cancer, nothing. In other countries like China, they are doing endometrial ablation for endometrial cancer also. Their protocols. But we don't recommend here.
Okay, for endometrial cancers, ablation.
Ablation first early stage.
That is for more time and more energy,
मग कुठे आहे?
Yeah, the different
or it is
protocols.
depends on
No,
the
no,
only
up
thickness.
till the myometer, more energy, more ablation.
Okay.
Yeah.
Sir, what is post-operative care and antibiotics you advise to the patient?
It's a normal, what generally we do, same normal, but no specific, same what generally you do, antibiotic, what same.
now
As
no
choice. No,
For how
What
many
is your-
days?
what is your
curate is the best option.
So
because
you
if
can do
want, simple thing. Yes, suction.
Suction.
Head low position. Yes.
suction cannula
You are doing curettage now.
Just not curate simple. I want to do some suction. I remove
yes
the debris.
I will give you suction
Just to debris I am removing. So
बस sir I will give you suction
section. Just section I want.
one
Can
minute
you
I will-
remove it with the plastic cannula and MUSC?
yeah,
that
we
is
are
the best
we are
Yes,
taking
That is the
they
best
are
option.
doing that.
plastic
only.
cannula
Yeah. Only section we do.
काय सगळे पिवळे उभारलेत हालत नाही
What debris slagging and like a beach ball moving, all debris remove, so it won't cause infection, pyometra, hematometra after that.
For how many days patient bleeds spotting after the procedure?
Yeah, generally normal watery discharge for 10 to 15 days we observed. After that is a normal one.
Does she get normal menses?
Yeah, good question. I am expecting that. So, she get normal menstruation, the regeneration depending on her hormone and regeneration of endometrium. Mostly people after 6 months. After 6 months they will get a scanty menstruation. If the leftover endometrium regenerate completely, she will scanty menstruation. It's not normal menstruation, scanty menstruation after 6 months. In future, young patient, hormone is normal, she will get a normal menstruation after 1 year, I think, mostly.
Can we give hormones to this patient after 6 months?
For hormone, for what purpose?
If she want to have a regular bleeding, then?
No, don't expect no, they don't want regular bleeding. If you want,
no,
you can.
few patients ask, that's why.
We can manage it, no problem. Slowly, sir.
Can patient become amenorrheic?
Yeah, different chances are there. They're 20 to 30% amenorrheic. Because if you over ablate endometrial, even the endometrium, that type of cases are menstruation not possible.
Any questions from audience?
Okay.
How frequently she needs to have an ultrasonography during the follow-up period? Means, I mean to say long-term follow-up of this patient.
No, we have a protocols like our microwave should go first post of day, then 1 month, then 3 months, then 6 months, 12 months cut off.
What is the role of copper tea? For how many days it works?
Copper tea, it's fully Indian context. We are because of apprehension to infection, but other countries they don't they do just section and D&C. But we observed some of cases they developed pyometria, one case. So for that reason, we are involving like a drain, copper tea. Okay. It's like a drain purpose. Okay. And moreover, the advantage here, beauty is, if you are doing a ultrasound guided, you can do the ultrasound guided any adenomyosis also same time.
Okay.
You can do combine with laparoscopy, endometrium ablation, so save uterus. That is the beauty of TCRE, overcome TCRE, whatever you do like hot balloons. There is advantage of this microwave. You understand, madam?
Understand.
Though there is like a two problem. A patient suffering with adenomyosis with a DUB. So adenomyosis can do transvaginal ultrasound guided as well as endometrium ablation also.
Okay.
Yes.
Now this case is finished, so you are starting with the new case.
Right.
Tuma inne chuskunem ada? Tuma inne chuskunem. Okay. Meanwhile, we can talk because we are taking the case here only.
Okay.
So you can have a conversation.
Yes.
Ghate madam.
Okay, sir.
तो आता सेकंड केस इथंच घेतोय आपण तोपर्यंत काही क्वेश्चन्स असतील तर सर उत्तर देतील त्यांचे.
Is this procedure is for fertility advancing surgery?
No, yes, that's microwave, especially adenomyosis. And you are a master in that adenomyosis fibroid. With the team of radiology, gynecologists, they can do the lab or ultrasound guided ablation specific to protect the endometrium.
Okay.
I told the endometrium protection very important.
Okay.
So the microwave kills normal cell, pathology cells. Try to understand.
Okay.
So we have to protect the endometrium with a supply of irrigation saline or simple under ablation. That side of you should not pass in the endometrium side.
Okay.
So you are should be away from the endometrium side.
Regarding adenomyosis, what I feel is even in that case, when you put a scope, adenomyosis removal laparoscopically is a very
complex surgery, difficult surgery.
Instead of that, when you put a scope and you are seeing the uterus and you can use this type of antenna and go to that adenomyotic spot, and if you destroy it, I think that will be easier to do than the adenomyosis removal.
Yeah, I told you, sir, laparoscopy, myomectomy is good.
Yes.
Adenomectomy is difficult. Microwave adenomyosis, it's very good results. Fibroid have lesser result. That's it.
So if you are having all the sets, this can be in your armamentum, so that
Yeah, yeah.
at various patients we can use it.
No, no,
Definitely.
it's another jewelry to the
Yeah.
gynecology.
No, gynecologists want only gold.
No, it's a platinum. It's a what you call, madam. This is not a what you call a. It's a tool in the box. Another tool. Another tool in your working box.
Okay. What you attract from general surgery to gynecology?
Yeah, it's very very important question in my life. So I married a gynecology.
Okay.
I thought she can able to do NDVH, MIVH. So she is not doing. For her, I learned NDVH from PC Mahapatra, especially for her. So after that, I teach everybody in Telangana, Andhra, all senior gynecologists.
Okay.
So I learned from Gurram sir also, bipolar seizure, especially. So we are doing a minimal invasive, NDVH to the MIVH, bipolar seizure. Okay, so for that is the thing to me forced to converted what you call a gynec. It's not gynec. So I am in that. After that, I have done my diploma in microwave in China, 3 months. So I thought this is a good energy, should reach the common Indian man. So I have to train, have to this energy to taste all the department. So I am giving this type of knowledge like microwave to the urologist and the oncologist or in interventional radiology, especially thyroid surgeons. They do thyroid nodules, thyroid cyst, even thyroid malignancy we are doing. So that is interventional as well as ENT surgeon, endocrine surgeons. So all the departments, one machine, all the departments. So we are giving some. It's not training. I'm just a supporter for all the people. So this is I have learned from China. So this knowledge I'm transferring to the all department.
Sir, but the cost of the operation is too much for the center like Solapur, like us. So can we reduce the cost of the surgery? And treatment should be within the reach.
Yeah. When I was in a PG student, that time the call storage laparoscopy is around one instrument is 25-30,000. You know the money. When I was a student, maybe that. So after now the 1,000 rupees, 2,000. So once we start like this cooperative hospital, multi-specialty hospital, so we'll have a next year we'll have Make in India. Make in India we can manufacture here. Yes, and the company China also associated with this here dealers. They are planning for some assembling some units and disposables at lower cost. So cost I think doesn't problem in future. The main thing.
No, it is problem. Yes, patients are not paying.
What I'm saying initially, madam. Initially it's 1 or 2 day problem. Initially how to learn, and next time maybe other companies now the J&J, even Covidien, they are manufacturing microwave. Even Indian company maybe 1 or 2 years.
You tie up with Indian company, reduce the cost to half, yes. Then we'll do on the patients.
Sure, madam.
In fact, in future, the instrument may come consist of all energies in one. So that a laparoscopist can use the bipolar, microwave, all in one instrument. That might come later. We don't know.
Yeah.
Any questions from audience? Anyone?
And this patient even blood thinner. Patient stopped. Still bleeding is not you are observing. That is the power. You understand, madam? This case was under thrombosis. So blood thinner, sir, already stopped. Still, you not seen in the hysteroscopy one drop of bleeding. Also.
For how many days we have to stop blood thinner before operation in these patients?
These type of cases, 3 days is enough.
And when to start again?
Again after 2-3 days.
Okay.
That's no specific. Even sometimes you may not require.
Can this surgery done into the cardiac patients? Can we do? Can we do this surgery in cardiac patients?
Sure,
because there are many patients coming with AUB, DUB, with the prosthetic walls. You cannot give the hormones to the patient. So what we can do for that patients? Those patients.
Under this type of, you can see simple paracervical block.
Okay.
You can do paracervical block and anesthesia guidance, some sedation. You can do some ablation like Simple with anesthesia help, you can do it paracervical block.
Okay, sir. Thank you, sir.
Right.
Sir,
Any other surgeries you are doing?
No,
General surgery in your institute?
no general surgery. I just trained for the doctors for laser proctology, varicose
Okay.
veins, thyroid, laparoscopy. I'm not much in hernia, all these things. Only my interested in the laser hysteroscopy.
Laser hysteroscopy.
I went to Barcelona, Dr. Sergio Haimovich, the
Okay.
world master.
Okay.
I got a training from him. He is doing all the hysteroscopic laser, diode laser,
Okay.
polypectomy, even enucleation, septal resection.
Okay.
So this I do hysteroscopic.
Okay, sir.
Sir, duration of hospital stay and advice given on discharge card. Which advice should be right on the discharge card?
Patient, it's a minimal invasive daycare procedure. You can discharge second day. If anything pain problem or suspecting any, you can keep one more day.
Thank you, sir.
Am I audible?
Yes, sir.
Okay. Regarding the next case, this case was admitted yesterday night. She is actually 21-year-old patient. She is having a fibroid of about 3.2 to 3.5 centimeter
Okay.
with some degeneration, and the fibroid is on the lateral wall of the uterus. There is a history of one abortion, and patient is having continuous pain in abdomen.
Okay.
So, as we are having this workshop, so I decided to keep this case because actually we are short of cases
Okay,
at
sir,
that
I
time.
know.
So we are actually this procedure can be done under spinal anesthesia, but
Okay.
here we are giving GA only because patient should not be conscious during all our discussion. That is
Okay.
the only aim.
Okay.
And we are using here IGL instead of intubation,
Okay.
because for intubation we have to go beyond the cords, but these IGLs are above the larynx, so all problems related to intubation can be avoided. And in
Okay.
fact, for many daycare procedure, this IGL is used, where you can discharge patient within 4 hours.
Okay.
Yeah. Thank you. And
Welcome,
for we are training this IGL not only for anesthesia, but also all consultant and also nurses and other worker, so that for emergency purpose anyone can put this IGL and ventilate the patient, especially during CPR.
There should be another workshop how to put the IGL.
Yes,
Ah,
definitely.
ah.
In our
If
hospital,
you are ready, we will take.
Yeah, no, in our hospital, whenever we take workshop for CPR, we
Okay.
always show them how to put IGL, and this is for all. Okay.
I know.
Our code blue team is already knowing about this
This,
IGL,
I
and in
know.
all code blues this is used many a times.
Oh, sir. I know, sir.
Focus here. Focus here. See, it is very easy to put up IGL. You have just to open the mouth and insert it. That's all.
Open the mouth, tongue retractor is done, retraction of tongue, and they put the IGL.
Hey, camera this.
JR1 resident Divya is there.
Yes, that's.
Okay, thank you, sir.
Thank you, Dr. Ganesh Chaudhary, sir. Very nicely you explain how to put IGL.
Sir, beated in. Sir, you want? नाही बोलवा ना त्यांना. सिस्टर सगळ्यात शेवटी मिथिलीन ब्ल्यू घ्या, म्हणजे एक काम होऊन जातं हिचं. फक्त फ्लुइड आत टाकून बघायचं.
Now the patient is anesthetized.
Yeah.
Now we are coming with the sonography of the patient.
Yes, I am
You are
painting the
preparing for
patient,
painting the patient for the operation. So coming to the sonography.
This is done under laparoscopy.
Okay. But in sonography, what type of fibroid it is?
She is having a lateral fibroid.
But intramural, subserous, what is
No, it's intramural.
intramural fibroid? So according to the FIGO classification,
As per my information, because I have not seen this patient.
so on sonography we'll see the patient.
We will do sonography, transvaginal. You can put, madams. Transvaginal.
Then we confirm the fibroid, which type of fibroid it is.
इकडे द्या, मला द्या, मी बघतो.
Probe cover.
नाहीये. प्रोब कवर खालनं मागवून घ्या. इथं नसणार आहे, खालनं मागवावं लागेल. अल्ट्रासाउंड डिपार्टमेंटला जाऊन प्रोब कवर्स घेऊन ये. ह्या कंडोम आहे का सिस्टर? मावशी हे करू. Transvaginal we will do.
Hello. Doing abdominal sonography.
Okay, wait. Sari is doing saline. You can put some saline here. So because no gel, saline.
There is a fibroid.
Yeah.
Yes, we are seeing lower side of the uterus.
Okay.
Laterally.
So radiology people will do with directly.
Okay.
Percutaneous from the here.
Okay.
Right side.
Fibroid.
Yes.
Lateral wall fibroid
And
is
she is
there.
having one history of abortion, and now you can put a Doppler.
Okay.
Increase. Flow increase.
This wall so edema abortion because congestion.
That is the previous.
Previous.
Not now.
Myometrium thickness is okay.
Remove the.
Okay. You come, sir. Lab, you start lab. Vaginal certificate.
7 नंबर. थोड़ा सा मार्कर क्या? 7 नंबर क्लोज.
You can.
Vaginal probe लागेल.
Vaginal is important.
abdominal आता झालंय, vaginal पाहिजे. नाहीतर एक काम करा, gloves वापरा.
You can put the gloves to the probe and then to transvaginal.
Laparoscopy ultrasound can shift it over there. Lab should come here, or ultrasound will come this place. No problem. You can shift here. Either you can shift. Take out wire and it this.
We are going inside now.
Yeah.
So better to clean.
Yeah, better. You can have police. No problem. No problem.
We will keep police catheter.
Otherwise no need. Post-op.
We can just. I will put simple catheter.
Doesn't require.
You are putting catheter to inflate bladder or deflate
No,
bladder?
deflating.
Just deflate.
I am just deflating.
Okay.
Like this, and always the height of the monitor should decrease, like your height. You will get neck pain.
But it is fixed. It is fixed.
After this, cut out. My advice: cut out always like same plane. That's better.
Now this OT we are shifting
Oh,
completely,
whatever. No,
and there we are having pendants.
Ergonomics.
Yes, we are having pendants.
Ergonomics. Yeah. Okay. Sir, come, sir. You can start left. Saline bottle, sterile IV set. Section sterile. 14 gauge, 20 centimeter. देखो देखो चेक करो.
You are doing this procedure by standing or you sit? Surgeon should sit.
No, no, standing only, madam.
Standing only.
Sitting.
Now we are just going inside the abdominal cavity.
Sir is starting laparoscopy.
Okay.
Now I will show you the antenna. It's a disposable antenna. Show them. This is the antenna. Trans-abdominal laparoscopic guided. It is a 14 gauge, 20 centimeter. You can see all the packing is coming.
Okay.
Hold.
Table కిందికి తీసుకో.
You see this antenna different from other antenna.
కిందికి తీసుకో.
Okay.
Okay. So the active tip you can see there. Active means here the firing zone.
Okay.
Block 1.
Okay.
This will totally will fire. You can see the conical for entry. Because of entry into inside. And you can have a marking. You have a marking like a 3 centimeter. It is like a 5 centimeter. It is Lakshman Rekha. We cannot enter more. So depending on size, the length of the fibroid, you have to enter. Okay. The ultrasound, the help of ultrasound, once you are entering in the fibroid, we cannot see in the laparoscopy now how we enter inside. You understand? Then the role of ultrasound is coming. You try to understand. See, under vision, I am entering into the fibroid.
Okay.
After entering inside, you are not seeing anything here. How you see ultrasound, you can see now by ultrasound. That is the reason lab assisted ultrasound guided.
Okay.
More advantage compared to the only ultrasound guided. Okay. This cable.
Sir, what is the cost of this antenna and all that set?
55,000, madam.
55,000. And if we want to use in another patient, then
Yeah,
how
you
to
can-
make sterile that?
No. Before that, you have to prepare for another case. You have to push out. There should not be in saline inside.
Okay.
Saline will be there. It forms crystal and black. It's out.
Okay.
To survive this, you have to clean with the spirit inside and gas inside. Clean it.
We
So
can
then-
see the laparoscope.
Then you do it ETO sterilization.
ETO sterile. Okay.
Before ETO, you have to maintain that is an empty. Inside saline, it is blocked. After procedure, make a air inside. Clean it with air.
So there
Understand?
should not be any weight
because
inside.
once saline it cannot rotate inside.
Okay.
It can't work.
Okay.
That is the reason.
Now laparoscope is put and we can see the bowels
Three
here.
एवढा वेळ लावतो.
थोड़ा इधर आ जाओ.
शी. माणसं 20.
Bowels we are seeing, that is you put the laparoscope inside.
Why is the police you can put otherwise? Take out. No need. Take out. Nikal. Police afterwards you can put out. No need.
Just 1 minute, we will fix this CO2 cannula.
Yeah, one more 5 mm.
Yes, 5 mm द्या.
One for section.
5 mm चे trokars.
You don't touch, sister. Okay. You keep it. 5 mm. I will hold camera.
No sir, no problem.
No problem. You just put one thought. Routine.
I generally.
No.
That leak. Karana sister.
Okay. I don't know.
You are doing second puncture.
Yeah, second. Same routine like a hysteroscope. Wait. Hysteroscope.
On the right side.
Same trocars, 5 mm trocars.
Okay.
Under vision, sharp trocar. Okay. We can manage with one trocar, but for demonstration, taking help of another trocar for clarity.
1 minute.
So one more.
We will just keep the intestines outside.
Thoda head low if you want.
Yes.
They pushed interest.
Here is the
you can see the fibroid.
Yes.
Very
At
well
the
on the
cornu,
lateral wall.
Yes,
Cornu
yes sir, at the cornu.
Very careful.
So
very well visualized.
You can come here, sir.
No,
I will
take another port here.
Okay.
Put another port.
5 mm there.
You keep there. IV shut saline. We'll put saline inside.
Okay.
Generally, we'll put a saline in the POD. It is called artificial ascites. You know the ascites, madam? The fluid inside we call ascites. So we are making artificial ascites. Okay. Okay, okay. So
The purpose of making
yes,
artificial ascites
it's
is
good.
not to
Yeah. So
injure
thermal
bowels.
conduction.
Thermal conduction to the
to
structures,
other structure like a rectum,
rectum,
bladder,
and
and even post-op
bowels.
pain also very less. So this is not possible in ultrasound, only laparoscopy advantage.
पाणी द्या.
How much fluid you want to inflate in the abdomen cavity?
How much?
How much fluid for
Fluid.
ascites you are
You can
making
have suction
artificial
cannula,
ascites with
She is getting
Sure.
suction
At
cannula.
At least 300 ml.
300
2 to
ml.
300.
Okay. Normal saline you are putting?
Only normal saline.
लागेल. Cannula. Yes.
You can say the size of the fibroid ultrasound report. Can you read?
It is around 2 by 3 centimeters, sir.
2 by 3.
3 by 3 maximum.
3 by 3
Sir,
means.
Can you put the vaginally some dilator?
No, not the, no, you put no, manipulator. No. This is for section.
Suction.
We can see the ultrasound. You can put with ultrasound support.
Ultrasound port.
Vaginal.
या तुम्ही या.
You come hold camera, sir.
Oh, I will hold it. You can come here.
थोड़ा नीचे जरा इधर.
From where we are inserting that microwave tip?
Yeah, fibroid.
In the abdomen.
The through abdomen. Yeah.
Are you from the 5 mm port or it is directly inserted?
No, directly inserted. No need a special port for this. You can see the fibroid.
We can see.
Okay.
Okay.
So we can do transvaginal ultrasound. You can find out, or you can have uterine manipulator. You can elevate the uterus,
Okay.
or with this instrument you can elevate it. Okay.
Okay.
You are seeing the fibroid, and you have to take care of tube also here to avoid the ablation. Right? You see.
It is
Okay.
just below the cornu.
Yeah. So very careful. The infertility case.
Yes, yeah.
So
Yes, sir.
we are very minimal ablation, under ablation,
Okay.
below 80%, right?
Okay.
And it is very small one.
You can
So
see here.
you can check.
That is at the round ligament. Exactly at the round ligament.
And see,
Here is the tube.
Nicola,
Okay.
Hey, there
You
were-
can see here.
Yeah. So
yeah, you can see here.
so if you see the ultrasound, so you can see ultrasound, but it's not a specific case to demonstrate actually. But we have the case. You can see the fibroid.
Yeah.
Okay,
Yeah.
I will hold. Forceps de do amma.
ఒకటి ఇది round.
You see now, you are checking here, I am at here. An ultrasound camera, you see? Maryland. Now the ultrasound is check, madam. Movement is coming, any movement over there? See, the ultrasound actually, come back. See, the antenna, for example, the fibroid is here, for example. So, once it goes that antenna, after that, ultrasound will play a key role. How
Okay.
much it inside, how is firing. So that is the reason. But after some few cases, if you done, generally we do only laparoscopy by our experience. Like it's a 3 mm, 5 mm fibroid is there here. We'll go inside, make a like a 3 centimeter, 4 centimeter will go inside, we'll ablate. But ultrasound initially it is useful.
Okay.
Right. So very careful.
You can use
Bob
that
Cox.
ground ligament.
Bob Cox, yeah. Bob Cox.
Lock wala de.
Simple, non-toothed.
Yes. You can use that round ligament.
You are manipulating uterus from lower end?
No, only ultrasound. You can
Only
manipulate
ultrasound.
also. After ultrasound, you can just for demonstration. So I am just catching the round ligament, just pulling here, it's right like this.
Okay.
We want to target here. So this area, okay? Very, you can see this. Now the tube is gone posteriorly. I am lifting and making center of this. You try to understand. Okay? Right. ऐसा करना सर एक assistant
Yes,
होना
1
पड़ेगा.
minute.
No, one assistant should come. Okay.
एक जण तिकडे जावा.
Sir, the bowel is just next to that.
No, we are not entering. Now the concept is camera. See, you can see the direction how you entered.
Okay.
Just keep holding. So you see now the pubic symphysis and the trocar point, camera point.
Okay.
So generally we prefer center for to enter the antenna. It's a hot needle, what you call antenna. If it is posterior, then you go for up. Anterior, just go down. You try to understand the because you understand if I go here, I cannot go to posterior.
Okay.
So I am always in this. The direction of inclination, the direction, if it is anterior, you can go center here. If it is posterior, you go up from here. This is very important.
Okay.
Otherwise, you cannot incline. How to
Incline,
go?
yes.
If you
Correct.
you cannot reach the posterior from here.
Correct.
Yeah, that is a trick, simple trick. But Gurram sir, anywhere he can go anywhere. So for beginners, you can learn this, right? So okay, we'll go.
For the posterior fibroid, we have to go up
Below umbilicus.
below umbilicus. That is just below the 10 mm port.
Yeah.
1 minute, sir. Are we getting?
No, we'll go. After this, we'll go.
Okay.
Wait, just wait.
Pakada.
Blade, 11 number blade. Camera back. You can utilize even this scope also you can utilize sometimes. So if it is in, you want lateral, you can go from here also. There is no, you can make your own road. There is no rule. So you can see now, camera clean. So now the entry is a 11 blade.
Okay.
It's the antenna. It is a hot needle. With the, but company called it antenna. I don't know why they put antenna the name.
Just
Camera,
1 minute.
वो एंटीना बोले तो हम लोगों को पिछले साल का टीवी
Yeah,
ऐसे
yes. Everybody is getting that down. So this antenna is entering now. Okay. Okay. Camera, some fogging. Yeah. So my target now.
Okay.
My target, you just push me inside. Yeah. Can you help me? This sister come.
Sister इकडे या.
కొంచెం.
त्याच्यात ठेवा.
It's a very small, this one. Yeah.
Okay.
So this is a tube. I want to go from here.
Yes.
Right? Okay. But though it is very small, I am cautious to do ablation because it look like some broad ligament fibroid. So broad ligament fibroid not good for ablation actually. Okay. I am entering you see now. Okay.
You are entering.
I am entering.
Okay.
You got it?
We got it. You are entering.
थोड़ा इधर लाओ.
इधर.
मेरा फोर्स दे दो, और एक फोर्स दे दो.
You are entering into the center of the fibroid.
Anywhere you can enter, but the matter is how to ablate is very important.
अच्छा, you want to go away from that.
Blood or something. No other.
So why broad ligament fibroids are not good for ablation?
Because the myometrium not much available to eat and dead tissue. You understand?
Okay.
So the dead tissue will come out from the cervical canal after ablating the endometrium. What? Then what?
Oh, catch us.
Phagocytosis, apoptosis, volume reduction.
Okay.
Can be done. Do here available, but not bleed. Maryland. No, this can be done, but very slowly. Yeah. No problem. Oh, wait. So, this is a tube.
Yes, that is the round ligament.
So I am inside the.
I am doing.
Right. Okay, understand?
Okay.
Now it's a bleeding started because of we are here not maintaining it out. Okay? Okay? See, I am inside. Now this will fix it.
Okay.
Hold it. Cable, wire, everything should fix now.
Okay.
Hello, Naka.
Now at this time you are only putting the antenna. The energy is not yet started.
No.
The cooling is not yet started.
Yes.
Okay.
Sir, it is
coming out.
Yes, came out.
Okay.
Came out.
Came out. No problem. We can see because some. Okay. Connection. Male female connection. Start cooling, start. Yeah, okay, sir. Camera back. वो sigmoid को नीचे कर दो सर.
वो जो बीच में आ रहा है.
सोडा.
You start with the 50.
Okay.
50. Okay, sir.
Same puncture you are putting?
Yeah, I'm trying to entering same puncture. Okay. Okay, I'm lifting now. Because vision is not good because we are making safety here.
Okay.
Okay.
No, we can see.
Yeah. Sigmoid को इधर
Yes, 1 minute.
Sigmoid is just.
Yeah, you cannot see
Just
sir because
side
I am lifting. So I am starting now. By ultrasound you can see some fire inside. You can see check the madam. You check it ultrasound. Don't small movement. Ultrasound. Yeah. Ultrasound. You see? Okay. Now you can see the carbon dioxide, normal cell and crystal in the antenna. Diamond antenna. You can see now.
Yeah.
Antenna became a diamond. So madam is doing ultrasound.
We are not getting some.
No.
That white color, that probe is converted into some white color.
No, you can't see madam now. Wait. I will show you. Wait a minute. Ultrasound you can't see. Otherwise we put a uterine manipulator, we can do it.
Yeah, that will be better.
Yeah, better.
Sound or uterine manipulator.
So you have to wait for at least 90 seconds.
Okay.
So 90 seconds, it uses a 1 centimeter tissue ablation. You understand, madam?
Understand.
So 3 centimeter we are expecting. So at least 3 seconds, 3 to 4 90 seconds. And I mean you can hear the sound here. Because now it has become a blind procedure.
We cannot hear, sir. You hear.
Voice. No, this voice.
Kutal.
Camera, okay. Wait. Tube, sir?
No, that is a round ligament.
Round ligament, no? Okay.
That is a round ligament.
Okay.
You can keep down that.
Down, but
Okay. So better we will put a
uterine manipulator.
uterine manipulator.
Otherwise, I lift like this and you can have.
That is okay.
No. After sometimes you observe the blanching. Firing is going on. Section, focus. I will show. Wait. No, uterine manipulator. Elevator. Wait.
Thama.
Wait.
Sir, one minute.
Clean, sir, clean.
I will clean once and then go inside.
Camera back. Instrument, you can use the instrument.
No. From same puncture they are going. From same puncture. Size.
Come, go catch and come this side.
1 minute.
Yes.
Okay, sir.
Camera. Okay.
Okay.
Firing is started. Hold like this. We'll see. 1 minute. We'll see.
Sir, how to determine the depth?
Yeah, that's ultrasound we have to do. But here ultrasound is not comfortable. That is a problem for us. And
It is lateral wall fibroid.
lateral it's some disturbance. Yes. Come this. Connection is good. Firing should start. Right? It's not working, I think, sir. So firing तो आ जाना. Check करो. कितना में है? 15 watts डालना. That's the. Yeah, the problem is a machine.
15.
You put 1550. That is the reason why it's not working.
They put 1.5 or
1.5,
5.0.
yeah, actually 50
We
they
also
should.
feel 1.5
Yeah, yeah.
because the size of the fibroid is small. That's why.
Ah, yeah, yeah, yeah.
Yes.
Now, you can wash it. Saline, section irrigation, saline, wash it.
ನೀಲಿಡ
Section on,
ಆಂಚಲ್ ರಿಮೋಟ್ ತ ನೀಡು ಈಗ
push it. Wait.
Huh.
That is, I am thinking about why it's not firing. That confusion. Yeah. Section on, okay.
both are available.
Okay, now okay. Now actually we had a mistake here because of watts not increased. Right, camera please. Dekho sir. Now it's good, yeah?
There are crystal formation over antenna.
No, that will happen common with cold saline carbon dioxide.
Okay.
The reaction.
Reaction.
You will get some blanching.
Not
No,
coming.
it's working something. Yeah. We'll see.
Yeah, it's blanching now. नुसतं पकडा
Wait.
थांबा काही करू नका
नीचे दे दो. Okay.
नॉट सर
Okay. 50 है. Document back. 60 you put 60. Sir, थोड़ा कैमरा क्लीन कर लो.
मैं करता हूँ.
Yeah, 60. Make it 60. We'll check this antenna working or not. I am getting doubt.
Okay.
Gel, wet gel, wet. Because I think it's a 16 gauge. No. 16 है, 14 नहीं है. काम एंटीना ही नहीं कर. Very mild it's 14 or 16 है. नहीं. नहीं आ रहा, हीट नहीं आ रहा ना, ज़्यादा नहीं आ रहा. थोड़ा अदर एंटीना दे दो. सहारा बट वेरी स्लोली आ रहा. और you increase the 80 watts. This is a technical problem will happen sometimes. Now it's slowly coming. We'll change the antenna. और एक दे दो. Stop circulation stop करो. 16 है, 14 नहीं है. और एक 14 दे दो. राइट टाइट हो गया. निकल. Keep there. Antenna please. They can elevate from the uterine manipulator and
Yes,
it's easy.
we will.
You do camera उसको अब आप जा दो सर, आप जाओ. You can do it.
एलिव्हेशन कोणी करताय का
हाँ.
स्पेक्युलम टाकलं थांबा मी टाकून देतो तुम्हाला हां टाका साऊंड टाका आपला वल्सलम लावून एखादा डायलेटर टाका फार आत जाऊ नका अँटीबायोटिक करा
No, 60.
एवढा नाही.
Okay. Now you can check the change the antenna.
रेट्रोवर्ट करा.
Now you can see now it is working. You can hear the sound. Okay.
Okay.
Now it's working. That antenna is not work due to technical reason. So we'll do wait section.
The sign of antenna working is that sound.
Yeah, sound, and you can see the heat
So
also.
we are not getting that sound. Now we'll get.
Yeah. We can check that one. We can by hand. You know, they can section on.
It's on.
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 Irrigation on.
Irrigation is also on.
Irrigation on. Right. You can elevate now. Now the antenna is working.
Okay.
ऐसे पकड़ो मैं इधर पकड़ो very difficult इधर
No, I will.
No, मेरा comfort रहना सर आप उसको पकड़ के दे दो
Okay.
round ligament
Round ligament.
आप पकड़ो round ligament छोड़ दो
Just 1 minute.
No, wait, start pulling.
Just 1 minute, 1 minute.
Round ligament.
This is a tube.
Yeah.
Here is the round ligament.
Okay.
और थोड़ा उधर. Yes.
Thapa, lava.
Okay. Right.
Yes.
So I'm entering now. You see now I'm entering because one hand okay. Right. From here I'm taking. Okay, now you can see. Right. Thoda idhar.
Right.
No. Just keep like this and you can away. Yeah. वहाँ touch नहीं होना. Okay.
पकड़ा सिस्टर है ना उससे पकड़ा.
Okay.
कहीं कर
Right. Because of 3 centimeter, here active tip also 3. We are unable to do complete inside. We don't know how lateral there we are unable to see. So I'm seeing. Now I'm doing. You see now. Now firing is started. You can observe the blanching and whitish everything now. Come camera close. You can see now.
Now we can see. Now we see.
You can see. Right.
Right.
Come close camera. No, this one. Yeah. Back. ऊपर करो sir थोड़ा. Yes. Yeah. You are observing now anything here? The whitish, charring, like a blanching.
Sir, we can see.
And we are cooking the fibroid.
Okay.
Inside. And you can make out by ultrasound, but here not possible this case.
Okay.
So this is not ideal case to demonstrate. Okay. So 90 seconds, this automatic will stop.
Okay.
So next we have to change the another side.
Okay.
This is pulse mode.
Okay. This is the pulse mode. What is the other mode?
There is a continuous mode. Continuous mode, you can have a continuous overlapping technique. Now you can see it completely. To the old time is. You can see that there is no bleeding inside. Okay.
You put in very vascular area, that is the uterine.
Yeah. I want to give one more shot, not more. Take a much risk in this case. And this old technique, back camera back, old puncture side.
Okay.
So there is no bleeding. You observe now. And it is mobile. Difficult to cannulate inside.
It is moving. That's
Yeah. That and our angulation and new team.
And as it is on lateral side, there is a lot of space to move the fibroid.
Okay.
Okay.
Right inside.
Yes.
Yeah, ice breaker.
Can you show us the ablator?
No, madam, it's not possible in here. It's very difficult to wear. once you are removing, if it is bleeding coming, then you do one more shot.
Okay.
So there is no rule like you don't do, not that.
Huh.
Can you?
Size is reduced almost half.
Yeah. On the intrapressure
tooth
only the
there.
water will come out.
Okay.
Now the shape is out, size is reduced, and only lateral side is there. We have to do this.
Yes,
One shot.
Tooth द्या बघू एक. किंवा असा-
1993, 290 second is
चपटा-
over.
चपटा काय का?
One more 90 second.
चपटा.
One more 90 second.
Yeah.
Yes,
Little
1 minute.
bit. Yes. But this camera, so it's angulation.
Right?
Not happy. Okay. Difficult.
You can go inside.
Yeah, going inside difficult, sir, because
Yes, 1
you
minute.
lift, yeah.
Now you can go inside.
Come, you push your side, sir. आपके लिए हाँ उधर ला लो. Okay. Right, it's moving. This is moving.
I think it is gone inside.
Yeah, it's moving.
Just
sir.
1 minute. Can I use some traumatic?
Huh?
Just 1 minute. I will use another.
Small
This is a
trocar you
good.
can use. That trocar you can use because it's very hard.
छोटा माइमेक्टोमी स्क्रू है क्या?
trocar होगा. Trocar कहाँ है?
क्या?
ये एक.
बारीक.
अभी यूज किया ना, उधर है ना. क्या है?
एकदम बारीक माइमेक्टोमी स्क्रू.
Switch off running. Tube pump. थोड़ा बेंड हो गया. Small one.
Sir, now you can use this.
Huh?
Now you can use. Yes, I am holding it tightly.
Because lateral spread is there.
No, but.
Hello.
Sir. Spirit.
पकड़ा.
Yeah, tell me, madam.
How many punctures you are doing again?
Actually,
Half.
my 3 punctures we want to try.
Huh?
Because our aim is one puncture is ablate 1 centimeter.
Huh?
It is 3 centimeter, no, madam.
Huh?
So we want to do 2 or 3 punctures.
3 punctures. Okay.
Yes.
Only one is remaining.
Yeah,
Tail
yeah.
doing. Huh? 2 punctures. But workable only 1 puncture done.
Cable spirit clean करके दो.
Second puncture is for only.
Spirit.
Difficult है ऐसा थोड़ा.
It is 50 volt, so that was not work. Huh. Zamre madam is here in audience.
Okay.
Madam want to ask.
Sir, you can. Now you can go.
I am going again. I am taking another antenna.
She said if the puncture is not work, how many you can use? 3 working punctures, no?
It's not here.
Huh.
We are using 10 mm and 5 mm.
You can use the 5 mm scope also, 3 mm scope. Generally, I use 3 mm.
Huh.
3 mm telescope or 3 mm instruments.
You will get, sir. Now.
That is called needloscopic.
Okay.
That is not laparoscopic.
Okay.
So the minimal invasive.
Okay.
So only the laparoscopy here to avoid bowel injury.
Okay, sir.
And you see that now sometimes cannulation difficult.
Okay.
60. Cannulation is difficult, so ultrasound we cannot do it. So laparoscopy with all this support, you can save coagulation.
Okay.
You can increase 60. Yeah? Okay. Okay. No, increase. Then you can see the bubbling over there. Come closer.
Yes, sir.
Yes.
Yes, sir. We are, sir.
Yeah. You can see the lateral also spreading. You can see the bubbling from other puncture. Cooking inside, steaming outside from the other. You are observing this bubbling from the another puncture here?
Yes.
Yes, sir. Limit of energy, how much we can use at one time?
No, depending on size of the pathology. I told you how to follow the route.
Maximum how much we can use?
Maximum is 20 minutes.
30. Okay.
It's all enough, sir.
Okay.
Okay, this is over.
See for
Huh.
any bleeding or not.
Any doubts you can ask, because this is not a good case for demonstration. So I will teach you now this.
Okay.
For example, if you put a uterine manipulator inside, you can fix the uterus and you can lift that. And easily, if you see, this is the back side, camera back side. This is the anterior fibroid. If you see, you can go easily and you can make a puncture inside easily like this.
Yes, yes.
It's easily.
Easy.
You can, easy. Because uterine manipulator make it fix it.
Fix
And
it.
posterior also you can go like it. And the length also, if ultrasound not work, you can see you have to go, you calculate length from here to the here.
Okay.
You can see this much length go inside. By manually you can calculate length like this.
Okay, sir.
And you can see the ultrasound also. Now you can see the ultrasound, check the ultrasound, take out. Gas release, camera clean. गैस स्टॉप no, पूरा स्टॉप कर दो, निकाल दो गैस, निकाल दो गैस, निकालो.
You do the suction after completing the procedure. You
generally-
created ascites there. no?
Yes, we do section, but still fresh saline 100 ml or 150 ml we will pour inside.
Okay.
That will absorb peritoneum. No, vaginal.
Vaginal.
Or abdominal you want to do? Abdominal you do, otherwise sterile. Vaginal, because of broad ligament you are not getting. Abjay, stop.
Now with TVS you want to show the.
No, because broad
Sir.
ligament TVS is not good. So we are doing
okay.
a transabdominal. Check this. You can see the fibroid. There whitish patch.
On the lower
is a
side there is a
patch.
patch. Whitish patch.
Right side pelvic. Yeah. You show
Okay,
me.
sir.
You show me. Yeah. You can see there. This
Yes.
white patches.
Yes, we can
That
see.
is
Yes,
the uterus
yeah.
and that is the patch.
Patch.
Yes.
Huh.
On the right side.
Yes.
We can
Yes, that is
appreciate.
the
sir.
patch.
Yeah.
Huh. Yes, we can see.
Okay.
Okay. Very nice demonstration of the case, sir.
Technical problem was happened.
Yeah.
Same thing sometimes.
No, the fibroid is
Yes.
broad ligament, lateral
yeah,
side,
yeah.
mobile.
The
There are
difficulty
lot
is
many
to-
problems.
Can you put some normal saline?
Yeah.
and suck?
I will suck out. Hold
समस्या
it.
होती चालू असू द्या.
Suction. Gas on.
Gas चालू.
Irrigation and suction.
Gas चालू.
Gas चालू.
I can see our whole team in operation
switch
theater. Naik sir, Gurram sir, Baldava sir.
So we do generally 3 mm instrument that is called needloscope. Very minimal
Okay.
invasive. We don't suture also. So their vision is important to only for safety for consent only bowel injury.
Okay.
So there is no bleeding after this. You can see now. Okay. And
Okay.
there is the shrinkage is there. Intra-op shrinkage. Post-op also it will shrink.
Okay.
And you can see now. Okay.
Okay.
Pose you see.
एक हे द्या.
Pre-op, you can check now how is the pre-op is there.
Huh.
Yes.
Suction, camera, right. And no need irrigation also in this because
Yes,
it is
yes.
in broad ligament. We are okay,
Yes. Okay.
right?
Okay.
Anything doubt, madam? Procedure
No,
is
no.
done,
No.
completed.
Sir, after how many days we should go for repeat ultrasound?
Yeah, there is a protocol follow up. Next day you have to follow whether any bleeding inside abdomen. Okay. Next day before discharge you follow. Then 1 month. That symptoms, any problem, anything, vaginal discharge, any
shrink
pain.
होतं.
Then 1 month you do the ultrasound.
तो shrink
But the
होतं.
shrinkage will less. But
नाही झालं तर
50%
काढून दे.
only volume reduction only 3 months.
Okay.
And the 6 months. Then 12 months, 1 year, then cut off, follow up.
Okay. And that is we have to do ultrasounds next
For
day.
serial
next,
ultrasound.
Next
Next
day.
day before discharge.
Next day before discharge.
Then
1 month.
Then 3 months.
3 months and 6 months and 12
Yes.
months. Okay.
Right.
And how much time it will take to shrink the fibroid?
6 months.
6 months.
If planning pregnancy after 6 months.
Any drugs you want to give in this patient?
No need, madam. Special drugs, I don't think. Like
No.
GNRH,
Huh.
GNRH analog antagonistic doesn't much required. But combination, if you have multiple,
Huh.
or you are misleading 1 centimeter fibroid, then you can add up that type of cases.
Okay.
Thank you, sir, for this nice demonstration of the cases.
Audio.
That is, the safety of the patient is most important. By ultrasound and combining laparoscopy, the safety is increased.